Welcome back to the deep dive. Today, we're going on a bit of a fantastic voyage.
A fantastic voyage.
We're shrinking down, hopping into the capsule, and taking a tour through the human digestive tract. We're looking at something that is visually stunning, sometimes a bit scary, and definitely misunderstood. And before we get going, I want to credit our guide for this journey. Today's insights come straight from Dr. G.S. Raju's YouTube channel.
It's a phenomenal resource. And today, we're looking at what are called vascular anomalies. Basically, blood vessel issues inside the colon and rectum.
Vascular anomalies, it sounds so technical, so sterile. But when I was looking through the notes, the visuals, they're anything but. We're not talking about, boring lumps or tumors.
Not at all.
We're talking about things that look, and they almost look like art.
That's a generous way to put it. But yes, they can be quite striking.
Striking is the word. We're talking bright, red, branching patterns. The source actually describes them as looking like a spider web.
It's a vivid image for sure.
A little unsettling, too. But the mission for this deep dive isn't just to look at the pretty pictures. We need to figure out what they are, where they come from, and this is the part that really got me. Why the best medical advice is often to, do absolutely nothing.
And that's the key. That's the counterintuitive part. We're so conditioned to think, find a problem, fix a problem.
Right. Cut it out, burn it off.
Exactly. But today is all about the art of clinical restraint.
I love that. The art of doing nothing. But okay, before we get to the philosophy, we have to deal with the vocabulary. Because Dr. Raju lists a few names for these spiderwebs, and they sound, I don't know, like spells from Harry Potter.
They do have that ring to them.
Yeah.
The source gives us three terms: angioectasias, telangiectasias, and angiodysplasias.
Oh, okay. Angiectasias, telangiectasias, angiodysplasias. Are these three different things? Do we need a glossary?
Thankfully, no.
Yeah.
For our purposes and for most clinicians, Dr. Raju clarifies that these terms are essentially interchangeable.
Oh, okay. Good.
They're all just describing the same thing.
So we don't need to get hung up on the words. But what is the thing? What am I actually looking at?
You're looking at a vascular malformation. The simplest way to think about it is like a freckle made of blood vessels.
A freckle.
Yeah, but instead of pigment like on your skin, these are made of tiny enlarged capillaries sitting right there in the mucosa.
And the mucosa is the inner lining of the gut, the wallpaper.
That's a great way to put it, yes. The moist pink inner lining. So you picture this smooth pink surface, and then suddenly there's this bright red starburst pattern.
Starburst.
Yeah, because it's capillaries. It's filled with oxygenated blood, so it really pops visually. It's bright red. And because they're dilated, stretched out, you can actually see the structure.
Which is where the spider web idea comes from.
Exactly. You can see the central point and these little legs branching out.
It almost sounds like a river delta seen from space.
That's a fantastic comparison. And it's not just a stain on the surface.
Yeah.
Dr. Raju points out a really cool detail. When you find these in the cecum, specifically, you can sometimes see a feeding vessel.
A feeding vessel. So there's a supply line.
Exactly. It has plumbing. There's a slightly larger vessel that's actively pumping blood into this little web.
That makes it feel so much more alive. It's not a scar. It's like a little unauthorized construction project.
That's a great way to think of it.
Okay, so we know what they look like. Red spider webs, sometimes with a feeding tube. Now let's talk geography, because where you find them seems to matter a lot. The source starts us off in the cecum.
Correct. The cecum and the right colon.
So for those of us who maybe skipped that day in biology, where are we in the body?
If you put your hand on your lower right abdomen, right near your hip bone, you're pretty much hovering over your cecum.
Yeah.
It's the starting point of the large intestine.
The starting line.
Yeah, it's the pouch where the small intestine connects to the colon.
Okay, lower right side, the junction point. So let's paint the scene. Patient comes in for a colonoscopy. Maybe they're just getting a routine checkup. They feel totally fine. The doctor drives the scope all the way to the end, gets to the cecum, and bam, there it is, the red spider web.
This is the classic incidental scenario.
Incidental as in, I wasn't looking for you, but here you are.
Precisely. The patient has no idea it exists. It's a surprise.
Okay, so this is where my instinct kicks in. If I'm the doctor, I see a malformed blood vessel thing. I want to zap it.
Right.
I got the tools. Why not just clean it up?
And that instinct is exactly what Dr. Raju warns against. This is probably the most critical takeaway for this part of the gut.
Why? Is it hard to get rid of?
It's not that it's hard. It's that removing it is risky. And leaving it carries almost zero risk.
All right, walk me through that, because leaving it just sounds wrong.
Think about the wall of the cecum. It's different from the rest of the colon.
Yeah.
It is significantly thinner.
Thinner, like weaker.
Think of the last part of the colon as thick, muscular. The cecum is more like tissue paper.
Oh. Oh, I see where this is going.
Right. To remove these, you usually use thermal ablation. You burn them.
You're applying heat to tissue paper.
You are. And if you burn just a little too deep, or if the wall is a little too thin in that spot, you can cause a perforation. You can burn a hole right through the colon.
Which I'm guessing is...
It's a catastrophic medical emergency, a surgical emergency. You've just turned a routine screening into a life-threatening situation.
All to get rid of a spider web that wasn't bothering anyone.
That's it exactly. So Dr. Raju has this really strict checklist. Is the patient bleeding? No. Do they have iron deficiency anemia, suggesting a slow leak? No.
So if the answer to both is no,
You do not touch it. You leave it alone.
the risk just isn't worth the benefit. Because the benefit is zero.
You're treating the picture on the screen, not the patient on the table. And the patient is much safer if you just respect the anomaly and back away.
That must be such a hard discipline to learn. To just sit on your hands when your brain is screaming, fix it!
It is. But that doesn't mean you do nothing at all.
Right. You can't just pretend you didn't see it.
No. Documentation is the answer.
So you take a picture.
Take a picture. Document the location. Cecum, right colon. And then, this is crucial, you have to talk to the patient.
How does that conversation go? Hey, good news, no cancer, but you have a spider web inside you.
Pretty much. You tell them, we found some angioectatic lesions in your cecum.
But why scare them if you're not going to do anything about it?
Because of the what if. What if 5 years from now that patient does start having some bleeding or they develop anemia?
Oh, okay. The future.
Exactly. A future doctor will be hunting for a cause. If they can look at the records and see, oh, look, there were documented vascular lesions here back in 2026, it solves the mystery.
It's leaving a breadcrumb trail for the next doctor.
You're building the patient's medical biography. That's your job.
I really like that framing. The doctor isn't just a fixer, but a chronicler. You're mapping the territory.
Well, that's a beautiful way to put it.
Okay, so that's the cecum. Thin walls, incidental findings, leave it alone. But the source takes a sharp turn here. We leave the right side and we travel all the way down to the other end.
The rectum. And here, the whole story changes.
In the cecum, these things were just there, nature's little quirks. But in the rectum, Dr. Raju says there's usually a very clear cause.
Yes. When we see these in the rectum, our first question has to be, has this patient had radiation therapy for cancer?
We're talking about collateral damage.
We are. This is radiation telangiectasia.
That's a heavy thought. You go through a life-saving treatment, and the treatment itself leaves a mark.
It's just physics. The rectum is right next door to some very common cancer sites.
Hey.
It's a crowded neighborhood down there.
Okay.
And Dr. Raju breaks this down into 2 specific patient profiles based on that anatomy.
So let's do profile number 1. Who is it?
Profile 1 is typically men who have been treated for prostate cancer.
Makes sense. Where does the prostate sit anatomically?
It's directly in front of the lower part of the rectum. They're practically roommates. They share a wall.
Okay.
So if you're blasting the prostate with radiation or even using brachytherapy, those little radioactive seeds,
Oh, right, the seed.
the radiation radiates. And the closest thing is the anterior wall of the rectum.
So if you're scoping a patient with that history, you'd expect to see the spider webs in a very specific spot.
Dr. Raju is very precise here. You see them in the lower rectum, clustered right above what's called the dentate line.
The dentate line.
It's an anatomical landmark, basically the border between the rectum and the anus. So you see these lesions right above that line.
And you know the history. The dots just connect.
The pattern matches the history.
Wow. Okay, so that's the prostate profile. What's profile number 2?
Profile 2 is women who have had radiotherapy for gynecological cancers, carcinoma of the cervix, or the uterus.
And the location of the spider webs changes.
It does. The uterus and cervix sit higher up in the pelvis.
The upstairs neighbors.
Exactly. So the collateral damage to the bowel happens higher up. You'll see the lesions in the upper rectum, or even in the rectosigmoid.
The rectosigmoid. The curvy bit just before the rectum.
That's the one.
So visually, do these radiation ones look different from the natural ones?
You know, if you just zoomed in on one single lesion, probably not. They're both dilated capillaries, both bright red.
So it's not the look of the thing itself.
It's the context. It's always the context. The location pattern plus the patient's history. That's how you make the diagnosis.
History is everything, really is the theme here.
It's the theme of good medicine.
Okay, I have to ask the intervention question again. For the cecum, it was do not touch. What about here? If a patient has these radiation marks in their rectum, do we fix them?
And that is the million-dollar question. And the source actually leaves us on a bit of a cliffhanger.
Oh, come on.
I know. Dr. Raju explicitly says that the management of these is a whole other complex topic for another time.
So tune in next week.
Kind of. But I think we can infer the guiding principle from the first part of our talk.
Which is?
Restraint. The rectum is thicker than the cecum, it's true. It's not as fragile. But you're still dealing with tissue that has been damaged by radiation. It doesn't heal as well.
It's already traumatized tissue. Burning it again feels risky.
Exactly. So while the rule might be more nuanced here, the general idea of don't intervene unless you absolutely have to still holds strong.
It's fascinating. We started this whole thing looking for freckles and spider webs, and we've ended up with a lesson in medical philosophy.
That's often how it goes.
So let's try to boil this down for everyone listening. What is the one big takeaway?
For me, it's the idea of being a silent observer.
Explain that.
We have these incredible high-definition cameras now. We can see things no one in history could see. We can see a tiny cluster of vessels in the colon. But the challenge is realizing that just because we can see it
doesn't mean it's a problem that needs fixing.
Exactly. The most skilled doctor isn't the one who fixes everything they see. It's the one who knows what not to fix.
It's the discipline to say, I see you, spiderweb. You look weird, but you aren't hurting anyone, so I'm going to document you and let you be.
And protect the patient's future by doing so.
It also makes me think about the radiation patients. It's a reminder that treatment has a long tail. You know, you ring the bell, you finish the therapy, but your body remembers.
It does. The body keeps the score.
Yeah.
And recognizing those patterns is a way of honoring that patient's history.
And it ensures you don't mistake a battle scar for a new enemy.
That's beautifully put.
Well, this has been a really fascinating trip through the colon. I never thought I'd be advocating for leaving spider webs alone, but here we are.
It's often the wiser choice.
A huge thank you to our expert for guiding us through the twists and turns of the large intestine today. It's been an education.
Always a pleasure.
And before we sign off, I just want to remind everyone where this incredible information came from. This entire deep dive was powered by the insights and visuals on Dr. G.S. Raju's YouTube. If you want to actually see these things for yourself, that's the place to go.
Highly recommended.
Thanks for listening, keep asking questions, and we'll catch you on the next deep dive.